Good afternoon. My name is Micah Burns. I'm one of the interventional pain physicians at ChangePain Clinic here in Vancouver, in Burnaby specifically. I'm going to talk today about stellate ganglion blockade in the central sensitivity population. So it's not an exhaustive talk about the possible benefits of stellate, but hopefully targeted to this group of people. All right, so topics in order here. So I'm going to talk about the autonomic nervous system, talk a little bit about the anatomy and how it affects pain, just so that we're all kind of on the same page when I start talking about what I'm doing when I do a sympathetic ganglion block as a sympathetic nervous system block. And specifically, I'll talk about the anatomy targeted towards that injection, the actual injection process, briefly, possible side effects and risks of the injection in that area. Then I'll go through some of the possible applications of the stellate ganglion block, which I reference a bit of literature and talk about kind of the strength of the recommendation based on the strength of the study to help inform everybody's thoughts around kind of risks and benefits. And then I'll talk about injections in general in the central sensitivity population, just kind of the way that I think about it. And then we can have a bit of questions around that time. Okay. So a little bit about the autonomic nervous system. So pay no attention to the right side of the screen. We're just talking about the left side. The green side is parasympathetic. So the autonomic nervous system is parasympathetic, sympathetic. It also includes the enteric nervous system like your GI tract, your gastrointestinal, but I'm not going to discuss that anymore after this sentence. So I know everyone here is probably at least partially aware of the sympathetic nervous system, because I'm sure actually Rick wouldn't let you get away with not working on your vagal tone. The vagal nerve is the most commonly known part of the nerve within the parasympathetic nervous system. So that nervous system is kind of the rest and digest, relaxation, digestion, energy conservation. And it has two origins. So both the brain stem, so some of the cranial nerves have parasympathetic nerves associated with them, and then also the sacral spinal cord has some outputs that are parasympathetic and sympathetic, a bit higher than lumbar. So these are very long nerves. Just talking about the anatomy. So they start and they travel throughout the body until they synapse or connect to the nerves at their target organ. So you can see the list there. It's the heart, the lungs, up in the head, it's the pupils and saliva. And it also controls blood flow throughout portions of the body. And then has issues, and then in sacral, of course, bladder and then genital innervation. So really long nerves, and they just travel through the body until they come all the way to their targets. So this is more specifically the sympathetic nervous system. And the anatomy is quite different, and that affects how I can affect it as an interventional pain physician. So this is the fight or flight system. It's kind of your adrenaline system, if you want to think about it that way, even though it's really a noradrenaline system. It's basically the same thing. It originates, instead of the brain stem, it originates from the thoracic and high lumbar regions of the spinal cord. So starting around T1 and all the way to L2. And then the nerves come out of the spine, and then they form these little ganglia or connections, or little collections of nerves right on the side of the spine, and all the way up and down the spine. So they go up and they form the superior cervical chain. So there's superior, middle, and inferior, and those are the ones that go to the head. And we'll focus on those later today. But I do want to just point out to you that they also form what is called a prevertebral ganglia, which form little right in front of the spine, little gatherings of nerves, and then they go from those gatherings out to their target. So those little gatherings, because they happen in the sympathetic nervous system and not the parasympathetic, we can inject those little gatherings of nerves, those ganglia, and so have an effect more easily on the sympathetic nervous system than the parasympathetic. So as I'm sure everyone's fairly aware, there's what you call dynamic antagonism, like a balance between sympathetic and parasympathetic to maintain homeostasis or balance between them. They respond to varying physiological demands, and the other one reacts to that. And the anatomical difference is why we can inject the sympathetic much easier than the parasympathetic. So just quick slide on this: autonomic nervous system and pain. So the immune system and the autonomic nervous system have lots of connections. So for instance, all of the like white blood cells, macrophages, those kind of things have receptors for the transmitters that the sympathetic nervous system and parasympathetic nervous system use. So when the sympathetic nervous system is activated, that activates some of the cells in the immune system. I'm not saying it makes them more active, but it has an effect on them. Transmitters that are released by the sympathetic nervous system sensitize pain receptors, which are on sensory nerves. So the sympathetic nervous system goes up, pain receptors on sensory nerves are more active and more sensitive. And the sympathetic nervous system being activated also can increase the inflammatory response. So it's a fight or flight. Your body wants to get ready to react and do things, both physically, like at the body level, you want to run, but also your body's ready in case some damage happens to it. It's ready to fight things off. So just in terms of the autonomic nervous system, low vagal tone is thought to be involved in several chronic pain states, fibromyalgia, of course, being the kind of poster child for that. And that's why everyone knows what box breathing is, probably around here. The autonomic nervous system controls blood flow, so it can directly cause ischemia and pain, like in Raynaud's phenomenon. Then there's internal organs. The pain sensations from them mainly come through the sympathetic nerves, which is why if you just going back to that sympathetic nervous system picture, you can see like if you have pain in your liver, pancreas, adrenal, I can do what's called a celiac plexus block, that second arrow to the right, and that can relieve some pain coming from the organ. So because it's a bit deep and there's some risks associated with it, it's something that's usually done, for instance, in cancer pain. But that is a sympathetic nervous system block for pain in the organs of the body. And then just so everybody's not mad at their sympathetic nervous system, the parasympathetic does bring some uncomfortable feelings back as well. Like the vagus is thought to communicate feelings of nausea or bloating. So to talk about the stellate ganglion anatomy and what the injection process is. So here's like a picture of the anatomy. So you can see I just put some squares on our target so that the word stellate ganglion has a square around it. It points a line over to a little yellow circle. Yellow by convention in drawings is nerves. And you'll see that nerve is surrounded by blood vessels on either side. And that is the bottom of 3 little ganglion that go up the cervical spine. So that's the stellate ganglion is a combination of the inferior cervical ganglion and the T1, the first thoracic ganglia. Only about 80% of people have it. 20% of people don't have this stellate ganglion. They just have the 2 different ganglia that haven't combined, just in case anybody's wondering. And then there's also the middle cervical ganglion, which is just a little bit up. And then the superior cervical ganglion up around, you can see like that's like C2 up there, C1, C2. So the stellate ganglion has blood vessels around it and also muscles, et cetera. And so this is kind of a cross-sectional view. So when I look with ultrasound, for instance, through the skin at the structures, this is a cross-sectional view that I would get. It looks like a little slice of the body there. So you'll notice that I put a big green arrow in there because that's the path that if I do an injection to the stellate ganglion, the path the needle takes through the skin, through some muscle, avoiding blood vessels, going behind the jugular vein, which is what brings blood down from the brain, and going behind the carotid, which is what brings blood up to the brain, and also avoiding the vertebral artery, which is even farther back, which also brings blood up to a different part of the brain, and injecting on the sympathetic trunk, which is kind of outlined in yellow and has a green highlight around it. So just to give you a idea of the picture, but those blood vessels are very easily seen on ultrasound. Some people do this with X-ray, in which case they use more bony landmarks. I don't do it that way. And I think more and more people are doing with ultrasound because it is just a bit faster and just a little bit safer. But don't be surprised if you get one of these and people use X-ray, it's also considered very safe. So how do you actually get the injection? Wear some loose clothing so the neck can be open. You don't have to take off your clothes or anything. We just need a little bit of neck opening there. You just lay on your back, face up. You disinfect the skin, put some ultrasound gel, an ultrasound probe on the front of the neck, just to the side of the trachea, no pressure on the trachea, the airway. The needle is inserted under image guidance. As I said, ultrasound's a bit faster. Local anesthetic is injected. The needle's removed, wipe off the gel. You can go to a recovery area for a few minutes if you like. Total time with needle in the body, including the injection time, usually less than 10 seconds, very quick overall. So, and the needle size is smaller than the ones that you put through your ear, for instance. So possible side effects and complications. So a side effect is an unintended effect of the procedure, positive or negative. A complication is an unfavorable result of treatment, usually with a bad effect on outcome, right? It has a negative connotation more so. So side effects, bruising or soreness at the injection site, you're breaking the skin basically. So you can have like a little, if you hit a little skin vessel, sometimes there's a little bruise there. The sympathetic nervous system provides feeling to this tiny little muscle in the eyelid. And when you block it, you get just a little bit of a droop of that eyelid. It doesn't close the eye, but you can get a little bit of a droop. And I see that fairly commonly. I just warned patients before. It goes away as soon as the local anesthetic wears off. So red or bloodshot eye, watery eye, nasal stuffiness. These are just effects of increase in parasympathetic tone relative to sympathetic tone. The sympathetic tone is blocked. The parasympathetic tone is therefore relatively higher. So these are the kind of things that you get, the hoarse voice. So there's some other nerves in the area which can be blocked. Again, that goes away as soon as the local anesthetic wears off. But until then, you can have a hoarse voice, a feeling of a lump in your throat, difficulty swallowing, or even warmth and tingling in your hand or arm. So this blocks the sympathetics to the heart, to the brain, and to the arm on that side. And so it can affect all those things. What I usually see is a bit of a droopy eye and a hoarse voice for about 3 hours. If I use bupivacaine, which lasts for 3 hours, or lidocaine lasts for about an hour. Rarely a bit longer than that. And I rarely even see bruising, really, just because the needles are so small. Possible complications. So infection, even if you get an infection, it's usually just in the skin. It's not really a deep injection. So it would just be a bit of a skin rash type thing. So I mean, you can fairly easily treatable. I've never actually seen this happen with this kind of injection. Bleeding from vascular puncture, nerve damage to the vagus nerve, the recurrent laryngeal nerve, which goes to your arytenoids and vocal cords, or the brachial plexus roots. You can have a pneumothorax. Sorry, brachial plexus is the nerves down to your arm. They provide strength and sensation to your arm. Pneumothorax, which is a hole in the lung. Thyroid injury, which is the gland right in front of your trachea, makes thyroid hormones, of course. And esophageal or tracheal puncture, which would result either in nothing or a bit of a cough or possibly infection like in the chest. Now, I think most of these complications are more common because they used to do this blind, like the lung is in vast majority of people nowhere near the area. But if you're doing this blind and you don't know that the lung has, and that person is a bit higher, maybe you'll actually hit the lung with ultrasound. But I just don't see the lung, and I can watch my needle go to the right area. And so I've never even seen a lung while doing this. And ultrasound is a live action needle, so the chance of hitting a vascular structure, or the thyroid, or these other nerves are much smaller. The risk is still there, of course. I don't want to say it's not present, but the risk is extremely small of any of these happening with ultrasound. So how can we use the stellate ganglion block? So this is just kind of the way that I think about it. This is how medicine in general thinks about these kind of things. This is not an exhaustive list by any means, but this is kind of the levels of evidence in terms of how reliable the results of the study are. So like a case report is like, we did this one time and, it worked for this patient. It means there's probably a bunch of other things that work better than that, but we exhausted all of those or most of those, or there was a reason we couldn't do them. And so we resorted to this thing that has very little evidence, and it happened to work in this case. And so, maybe it'll help other people, maybe it won't, who knows. Case series or retrospective study is like, we did this more than one time on a series of patients that all had kind of similar presentations, and here's kind of how it worked or didn't work, but you don't really know why or why not. And there's a lot more bias put in this way. Because you're going back to gather the data, so you can miss things a lot easier. A prospective case study or case control study, you're gathering the data as you go. And so like you decide to do it, you decide what data you're going to gather, and then you do the thing, and then you collect the data and you analyze it. And a lot more bias is taken out of it this way. So you can rely on it a bit more. It's still not kind of the gold standard, if you will, but at least it's a bit more. And a lot of what we do in central sensitivity is based on retrospective studies and, if you're lucky, prospective studies. Some of it is randomized control trials, which is the bias is defined and hopefully removed as much as possible. But at least you have some idea of the conditions in which the trial is taking place. And then, so you can rely a bit more on this. And like a large multi-center randomized control trial is some of the best level of evidence, and you can move forward with changing your practice considerably and reliably based on those. Not to say that they're always right, but it's usually the best level of evidence you have. And then if people have taken the time to do multiple randomized control trials, which is amazing for them, and then someone goes through and analyzes all those together and tries to kind of make sense of, because sometimes you do a randomized control trial and they don't agree with each other, but when you put the numbers together, you can get an actual sense of, once you have 1,000 patients, and you can get a sense of, is the thing that you're testing actually worthwhile on a large population in multiple different ways, multiple different kinds of populations. And so you can really rely on that. And I just want to say this because a lot of people have studied stellate ganglion. I try to make them all the things relevant to this group. So a lot of the things that I included do not have very good evidence. I just want everyone to understand how much weight to think about putting on each of these indications that I talk about. Because some of them, you always have to weigh the risks and benefits. And sometimes we just don't know the risks and we don't know the benefit really. Maybe we're all used to that too in this world. So complex regional pain syndrome, best evidence there is, super rare disease process, but one that's treated by interventional pain physicians. Because we can do these sympathetic nervous system blocks. This is specifically sympathetically maintained pain in a limb usually. And so doing a stellate ganglion block can be very effective for these patients, and they're in such immense pain, and often medications are not that helpful. So I mention it here because this is something that I treat as an interventional pain physician. It's the reason I know how to do stellate ganglion blocks. It's part of my training because of this disease process and so it's been understudied, but still, and yet, fairly well studied, in that there are meta-analyses of randomized control trials. There's great evidence that this is effective and should be tried in people that have complex regional pain syndrome, the stellate ganglion block. So just to talk about a few things that are like case report level evidence, just as like a discussion point. So this is not an exhaustive list, just some things I thought were interesting that might be interesting for like the central sensitivity group. Burning mouth syndrome, a lot of people have that. There's just a case report that helped one person. Restless leg syndrome and people that are on dialysis. So you can see how the population is so narrow. Idiopathic facial pain just means pain in the face. We don't really know why they have it. So they tried this stellate ganglion, helped. Cancer-related facial pain was like, 3 cases. It helped some of them. And trigeminal neuralgia helped one person. And you got to realize when people publish case reports, that means that probably other people have tried it and it didn't help. And then those don't get published because, I do these all the time. I don't publish every single one I do. So we never really know, but, it's just interesting that for some people, if you tried a bunch of other stuff, if you got restless leg syndrome, there's so many other things. Like you got to get your iron tested. There's a whole bunch of meds. You can do your mindfulness stuff. If nothing else is working, okay, so then maybe try a sympathetic block. If your quality of life is so bad, well, maybe the risks of the block, which are, as I discussed, not that bad in real life, are maybe worth it. And so to get into a bit higher level data, so case series retrospective study, postherpetic neuralgia in the face. So you get herpes zoster. There's kind of mixed reports on this one. So there was no really definitive evidence either way on this. And then plus they're all case series and case reports. So who really knows? But some people report benefit, some people don't. It's quite a painful thing, herpes zoster in general. Postherpetic neuralgia, super painful. There's some kind of mixed evidence that doing a sympathetic block while it's still fresh, like while you still have the rash, like as it's emerging, can reduce the risk of it turning chronic. Some other studies shown that's maybe not the case, but it can be pain relieving in the moment, and there maybe are ways to elongate it. So anyway, a bit mixed on this one. Chronic migraine. So chronic migraine, definition of that is at least 8 migraine days in a month with a total of 12 headache days. So like four other days you have some kind of headache, even if there aren't a migraine, and you follow that for 3 months. And if every month you're meeting that minimum number of headaches, then you have defined chronic migraine as a diagnosis. So people tried ultrasound-guided stellate ganglion blocks for the treatment of chronic migraine, specifically in an elderly population. And this is, so everybody's over 64, so 65 and above, just a retrospective study. So they did it on a bunch of patients, and then just go back to talk about it. And in this group of people that they did the injections on, we don't know why they did them on this group and not other groups, et cetera. Why they chose everyone over 65. Maybe they just like the results on their stats. If they would have included everyone down to 60, maybe it wouldn't have worked. We don't really know. But in this population, it reduced headache days by half, so down from 23 to 10, which is pretty good. And each headache that the patients got was shorter. So migraines have to last about 4 hours by definition. So, but they can last way longer than that in some people. So each headache that patients got, they reported as shorter. And the effects from the stellate ganglion block lasted for about 3 months. And 64% of those patients were able to lower their acute medication, so the abortive medications, by about half. And they didn't report any serious adverse events. So that's pretty good. It says that maybe this is a good technique for people that have chronic migraine. And again, And there was a small study, I'm just referencing the two little sentences there at the bottom. There was a smaller study, just 20 patients per arm, prospectively done. They weren't randomized because 20 of them had chronic tension and 20 of them had migraine. So there's no randomization or anything, but they did it on both of those groups, and it worked about as well on the patients that had chronic tension headache as patients that had chronic migraine in that very small group, right? It's not a huge group of people, but that's pretty good. That just to say, maybe it's a treatment option if other things aren't working. And again, in intermittent migraine, this was a prospective cohort study, but it's not chronic migraine. So I didn't want to make that kind of my headline case, but in patients that had intermittent migraine, generally the average number is 4 or 5, I think, in this study. And it helped in intermittent migraine. They got reduced number of headaches. Then again, there's so many other things that help with intermittent migraine. So this would be more for people that maybe can't handle medications because of the side effects, but can handle injections. Like the injection side effect is not as bad as the medication side effect, or can't access some of these newer and expensive medications like the CGRP inhibitors, or sorry, the GPINT class of medications, which are good for kind of intermittent migraines. So anyway, effective for both chronic migraine and maybe for chronic tension headache, and in that prospective cohort study for intermittent migraines, so less than 8 per month. And just to say, they weren't doing it, it wasn't just one stellate ganglion block. It was usually, they did them like every week times 4 or twice a week times 4 or something like that. So they were getting a couple stellate ganglion blocks and then following them for a while. So long COVID, which is basically ME/CFS, right? So, and this is how I started using it more often, was this original case series of just 2 patients. They're both female, which seems to matter in this kind of thing. They got bilateral stellate ganglion block, one side, the next day got the other side. And those patients had like full-blown long COVID, breathlessness, the fatigue, the brain fog. They had the whole gamut, loss of smell and taste and everything. And they had almost complete relief of severe fatigue and brain fog. And they followed them out to 60 days before stopping the following. But those 2 patients did really, really well. And so people started doing it more. And, we saw that and we started doing it more at our clinic, because the people that had this were suffering so much. And so other people were doing it too, obviously. And so they eventually did a bunch of patients and then published a retrospective study on how they did. So Stellate for long COVID. And no one's done anything on actual chronic fatigue, just to say. But, if you view them as basically the same thing, then maybe they have. But anyway, there was 18 male, 23 female patients in that retrospective study. 86% of total patients reported reduction in at least some symptoms, which is pretty good. 61% reported complete relief, which is, I don't think, been what I've seen, but maybe that's just their study. Brain fog and fatigue were the most likely things to improve, and they tended to improve at different rates. So there's like, some people have benefited within a day, like had the brain fog and fatigue reduction within a day, but it could keep improving out to 2 weeks. So some people would get the injections and wouldn't see the effects for 2 weeks, but then started seeing the improvement, which is interesting. And the reason it seems to matter if your sex is male or female is that women had more total number of symptoms reported when they went through and recorded, just a checklist of symptoms. But women also tended to respond at higher rates to the stellate injection. And there is a difference between, women and men in terms of getting autoimmune disease and migraines. Men tend to get more of the cluster headaches and tend to get more the seronegative spondyloarthropathy. So like ankylosing spondylitis is more men, and lupus, that kind of thing, is more women. So there is maybe some kind of difference in the immune system. And so if you're talking about the sympathetic nervous system and its interactions with the immune system, and maybe that's what this injection does, then maybe that's why there's some kind of difference that they're reporting here. Anyway, it needs to be studied more, obviously. So getting into more like prospective studies, this was loss of smell and taste associated with long COVID. So nausea is like lack of smell. It's just a single arm pilot study, just 20 patients. They did bilateral stellate one day, then the other day, and then followed for a month. And most of the patients had increased smell scores, which I don't know. I don't deal with smell scores. I guess there's some validated score. I don't know how you, maybe they went from nothing to a little bit of smell. Seems like a hard thing to have a percentage increase on, but anyway. That was good. So it works for some people. And then in this retrospective study, 195 patients, 75% of those 195 patients responded with at least partial improvement to smell and taste after stellate block. Some patients just got it on the right, some patients got right and left. I don't know how they decided to do that. That's why it's a retrospective study, because they just sort of did it and then reported on it. But I thought it was interesting. They followed up on those patients within 7 days, and still 75% of patients responded with at least some improvement in smell and taste. I've only seen maybe like 5 patients just for this, like that didn't have other symptoms of long COVID, that just came in with, I haven't been able to taste anything for 2 years. And maybe it's because they've had it for so long, the patients I've seen, or lacked it for so long, that it just seems like this is the hardest to get back. Like I've seen pretty good results with the fatigue and the brain fog, breathlessness even. But the smell and taste seems pretty tough. I have one patient we've tried maybe like 5, 6, 7 times now. I don't remember, but she's just starting to get back a little bit of smell. Anyway, we're working on it. And by working on it, I mean continuing to do bilateral stellate ganglion blocks like every month, basically, just to see if we can help. So randomized control trial. So this is stuff like you can hang your hat on until something better comes along. This, pretty good chance of helping, basically. So the vasomotor symptoms of perimenopause, hot flashes, right? So there's a randomized control trial. There's also a bunch of less rigorous studies. So there's, a bunch of case series and retrospectives and et cetera. And so someone, there's enough of that till finally someone decided, okay, we got to do a real study. Got to find out what's happened. And they did stellate versus a sham block. So they actually put a needle in, but didn't do an injection. Still kind of a small study, just 40 patients. But then they followed them for 6 months after the injection. And they found that the stellate ganglion block reduced the worst of the symptoms for 6 months. No change in the frequency of the symptoms. So they still got it, but it wasn't as bad. And not this study, but other studies that I found showed some improvement in sleep disturbance. They didn't have to find that in this study, but maybe it'll help a little bit for that. I thought this was important because a lot of people, like breast cancer survivors, can't be on hormone replacements, chronic pelvic pain, endometriosis patients might be basically put into menopause, bilateral oophorectomies, taking the ovaries out. Some people just can't handle pharmacologics, like can't take hormone replacements. And so a lot of people are in perimenopause for various reasons. Now, this was mainly people that were in like just over the course of their natural life had gone into perimenopause, but I think it's worthwhile to take this kind of information and apply it to anybody, right? Like if you're 30 years old and you got endometriosis and that you've been put into basically menopause with pharmacologics and you're having hot flashes, maybe this is a good way to increase quality of life, at least a little bit, maybe help your sleep a little bit. So post-mastectomy pain, I bring this up mainly because it's like just a chronic post-operative, so people had a surgery, nerve pain, almost always. And also they did something interesting here where they used radio frequency energy to elongate the effect of the stellate ganglion. So it's a randomized trial. It's not really a good control because what they did was continuous radio frequency, which causes heat to build up and actually cauterizes the area around the needle. versus pulse radiofrequency. So the radiofrequency energy is applied a few times a second, gives it a chance to dissipate. And so you don't actually, there's no heat buildup when you do pulse radiofrequency. You just apply the radiofrequency energy to the nerve. It kind of shocks it. It takes a couple of weeks to have an effect, but the end result is it turns down how often pain nerves fire. Shock it sounds scary. You don't feel anything. It's like when you get this, everything's numb. You know, I usually, when I do pulse radiofrequency, I'd usually turn on some music because otherwise it's a bit boring. You know, I've had patients fall asleep during that because literally you don't, with the needles in, you pulse for like, 6, 8, 10, 12 minutes, 20 minutes. You literally don't feel anything because everything's just frozen. So anyway, in this patient, 80 patients, so about, half per arm, they did the radiofrequency to the stellate ganglion, comparing pulsed to continuous application. And both arms actually showed significant reduction in pain meds, pain intensity, and increase in quality of life scores. So I thought that was pretty good. So there are ways. So we do stellate ganglion injections with local anesthetic, and this is referencing a way to elongate the effects. And also post-mastectomy pain is really bad. So it's nice that there's ways to treat it besides meds. So fibromyalgia, this is all the way from 1988. They did a randomized trial. So I don't know, randomized control trial in 1988, like statistics have apparently come a long way since then, as well as trial design. So I don't know if this kind of thing would pass muster these days, but anyway, it's 3 arms. They did stellate ganglion block versus IV guanethidine. Guanethidine, you inject into the arm and then it causes release of all the sympathetic. So basically the sympathetics are exhausted. So you don't have sympathetic outflow around those veins versus control. So patients got nothing. And stellate ganglion block reduced tender points and resting pain in the arm on that side where the injection was done. So like the right side block, right side arm. And it was more effective than the IV guanethidine and definitely more effective than doing nothing. So it didn't treat, I think it's kind of a funny, it's more like a proof of concept that you can turn off the pain in a certain area, but of course fibromyalgia is like widespread pain. It's not just in one limb, but interesting that you can do this, so maybe there is some part of fibromyalgia that is affected by the autonomic nervous system or by the immune system, right? And there's some evidence about like small fiber neuropathies and affecting the DRG and stuff. So maybe there's something there. PTSD. This is a multi-site randomized control trial. And so, really good study. They did 2 right-sided stellate ganglion blocks. They were 2 weeks apart versus sham procedure. So patients had a needle in their neck, but didn't actually get the stellate ganglion block injection. It's kind of a specific population, but it's mild to moderate PTSD, active U.S. Army service members. So that's probably not the population I'm talking to right now, but still PTSD maybe is PTSD, no matter where it comes from. I know there's like PTSD, complex PTSD, but the treatments for it aren't necessarily maybe so different. Maybe not. I don't know. At least at the level where I'm doing an injection, maybe there's not a difference, when you're talking about the counseling aspect, but for someone like myself, just doing an injection, maybe PTSD is PTSD, maybe this is helpful. And for those patients, it reduced total overall symptom severity out to 8 weeks, and there's no further follow-up. So like I do this for several patients, and what I tell patients always the first time is, we got to do 2. There's another study where they did 3. So sometimes I tell patients 3, and it's going to help, but I don't know how long. And then I have no data to tell you how often you have to get it in a follow-up, right? Do you need it monthly from then on? Do you need it every 2 months, every 3 months, 6 months? Like what's the minimum effective dose of stellate ganglion block? I don't really have any data for that. So usually I just let patients kind of tell me, like it's starting to wear off at 3 months. Okay, so let's do it every 3 months for a little while. And then we'll try and stretch it basically. So there's also I thought interestingly, a small retrospective study of 10 patients, PTSD symptoms. It was all the patients who had failed right side stellate ganglion blocks for PTSD. And so they just went and tried left side for those patients, and it worked on 9 to 10 of them. So that's pretty good. So maybe if, you do the right side, because that's got the evidence, the best study shows 2 on the right side. And if it doesn't help, then maybe try the left side. So dysautonomia, super common in long COVID, like POTS is very common, orthostatic hypotension, syncope fainting, less common. There's nothing on this by itself. They talk about dysautonomia and the long COVID thing. So all those people have dysautonomia symptoms, and they seem to be treated with stellate ganglion blocks, but there's no, I've had, I think 2 patients come in with just POTS and just say, I want to try this. Basically, they read it on the internet. And there's lots of stuff on the internet. I was like, I went and looked it up when they told me, just to see, it's on Reddit and all those kind of things, as well as what's the other one? MCAS, the mast cell activation syndrome. So, but anyway, there's no actual like literature on that. So I got no idea what to tell people. Basically, it's like if your quality of life is bad, I'll talk to you about the risks of this injection and tell you that there's very possibly going to be no benefit, and then maybe you can try it. But there's no like literature to discuss in this one. So that's all the things that I thought were kind of interesting or applicable to this group. There's tons of other stuff, people that have really bad tachyarrhythmias like ventricular fibrillation, and not ventricular tachycardia. You can do stellate ganglion blocks, and that can help, electrical storm type stuff. So there's tons of other reasons that people do stellate ganglion blocks, but I thought that was a pretty a good sample for this group. So ways to elongate the effect. So usually we just inject local anesthetic. Lidocaine lasts about an hour. Bupivacaine lasts about 3 hours. So how can you make it last longer? Well, as in that PTSD study, just repeating the injection a couple of times and see if that helps. Just local anesthetic, right? Local anesthetic has no systemic side effects. It's not a hormone like steroids, and it just sort of dissipates and it's gone. But if it doesn't help to just repeatedly inject it, sometimes you could try a bit of steroids, and we do sometimes. So corticosteroids, we use the word cortisone. Sometimes that's not a real thing, but corticosteroids is like the like overarching name for that, like the category. I think cortisone's from like 40 years ago, but anyway, and then but I try not to use steroids that much in my practice, which means basically just a couple of times a week I inject steroids, as opposed to, 20 years ago, that's what every single patient would get, a block with steroids. But it has there's a bunch of side effects that go along with getting too many steroids, including, the fact that they're just kind of hit or miss in a lot of things. So I don't really like to do them. It's a hormone. It can affect all these other things in the body. So if I can do things that are more targeted and have a more reliable effect, then I do those. And those things are this. So pulse radio frequency, as we talked about, radio frequency energy being applied to the nerves for pain control. So when it's pulsed, it interacts mainly with pain nerves, like these tiny little pain nerves, and reduces the likelihood of them firing. So reduces pain. It takes a couple of weeks to kick in after the procedure, but can be effective. Continuous radio frequency creates heat. It builds up and actually cauterizes a small section of tissue around that needle. You put it next to a nerve, cauterize the nerve. So it's more definite to affect the nerve because the nerve isn't there anymore, but it's also a bit more risky. Applying heat, you can damage surrounding structures, risk of increased pain depending on the nerve. So cryoablations using cold to burn the nerve probably has a lower complication rate, mainly affects smaller nerves. It's just newer in general. Way less evidence surrounding it because it's just newer. And at all the non-healthcare authority pain clinics, at least as far as I know in the Lower Mainland, there's a cost associated with radiofrequency or cryoablation. And most places would prescribe the steroid. So whatever that costs you at at the pharmacy. And then, but if you can get it within a healthcare authority, of course, they supply everything, right? So like St. Paul's has a pain clinic, Nanaimo has a pain clinic, Victoria, in Surrey, which is not an exhaustive list, but all those places do all this kind of stuff. I don't know exactly what they do. I don't want to speak for them. You know, everybody, different physicians are comfortable with different procedures and treating different conditions, but the cost of these procedures in general is covered under health authority budgets. And just to mention, you know, if you remember that picture way in the beginning of the anatomy, the stellate ganglion is the inferior cervical ganglion. Sometimes you can do like middle cervical ganglion. If just the stellate's not helping, sometimes we'll just go up a bit into the middle, a superior. There's no data around that, but sometimes this helps and the other one doesn't, and whatever, just adding it can be helpful. The effect should be basically the same, but there's no real studies, again, to support its use. But it's sometimes something we use as like a bit of a rescue, just as a trial. So injections in the central sensitivity population. So there's tons of injections that are available in general. And I've promised Dr. Arsenault another presentation on just like, you know, basically back pain, neck pain, that kind of stuff. But at least in my, you know, I see lots of people with central sensitivity of various kinds. You know, it's a population that needs a bit more care, right? Compared to like a 45-year-old runner who has, you know, a bit of knee pain or whatever. So needle-based techniques just don't work for some people. They get crashes, they get flares, it only needles, whatever it is, their anxiety is too high. This is not going to work for some people. And you might be one of those people, and knowing that, like if you're not gonna be able to handle the needle, that's totally fine. Like just don't push it. But you know, sometimes it can be worth it to at least try these things. For some people, they can be really helpful, and it can be worth like just the poke of the needle and the risk of the injection. Stellate seems like, you know, if you got really bad fatigue, stellate seems like something that is worth it for a lot of people. But I say that, you know, as a general thing, but you know, if you're someone that crashes super easily or gets flares of pain with just little tiny injections, then you can that crash or that flare of pain can totally negate the effects, the positive effects from injections. So I don't really have an answer for any individual on whether these things are worthwhile. It's kind of just has to be something that you decide. Sometimes I do know that the risk is too high. Like I'm just, you know, as a physician, I don't offer procedures sometimes because, you know, the risk of increased pain is too high, et cetera. But generally I try to let patients make their own decisions after I've informed them of the risks and possible benefits as much as possible, right? That being said, like I had a patient the other day who got brought in on like an ambulance brought her in because she can't stand up without getting nauseous, and it's been that way for a couple of years. And so we did stellate ganglion block one day, did stellate ganglion block the next day, and she walked to the bathroom for the first time in years. So, you know, she was like, I'm probably going to crash, and she didn't. And that was a really good effect. And it's really nice to see. And so she took that chance. You know, there's probably lots of other people who would have done it and maybe it would have been a horrible benefit, you know, no benefit for them at all. And you don't know who you are until you try these little things. So a lot of times what we do is have people go for something like unless they just want to try to, some patients get referred just in for stellate every once in a while. But a lot of patients come in, we just try like little trigger points. They're very gentle, not many needles. You just see how you respond to those kind of things. For some people, that's great, along with a bit of physiotherapy. And then, you know, you can kind of try other things as you find out how you respond to things. So just a quick recap, we talked about the autonomic nervous system, a bit about anatomy and function, why the stellate ganglion block as a sympathetic nervous system injection is easy because it's right alongside the spine, as opposed to, for instance, parasympathetic blocks, which the nerves are just super long. There's not necessarily good targets. Some applications of the stellate ganglion block in the CSS population, and then a bit about kind of just my thoughts around injecting the central sensitivity population. And there's the stock photo that pops up when you write questions, which we can do now.
I think you have 42 questions waiting for you.
Told me how to do this. So I'm going to stop sharing here. So first one, treatment for chronic daily migraines. Yep, chronic migraine. If there's no, we don't really have a criteria for people to undergo stellate ganglion. It's just a discussion with the physician. Whoever, there's a couple of us that do the injection here at the clinic. So we don't have like a predetermined criteria. So the question about reducing, yeah, so I've done this on patients that have chronic fatigue because a lot of patients, I was doing it on patients that had long COVID. And so, I think there's a study that came out, which I referenced in the procedure or in the presentation, that basically they're kind of the same thing. Seem like there's so many overlaps, all the scores on all the things the same. Anyway, so I just started doing it in patients that had chronic fatigue and kind of mixed, is a bit mixed, but I think long COVID's only been around for so long. So people only had long COVID for a certain amount of time. Some people have had chronic fatigue for years. So maybe that's the difference, like how long you've had it. Maybe you have to do more stellates, or maybe stellate is no longer an option after a certain point in time in a given person. In terms of anxiety, I have not asked that question. So I don't know if it reduced their anxiety. No one's actually told me I have very high anxiety and that no, I don't. Now for PTSD, I've had patients tell me that their PTSD gets better, including their reactivity and like panic attack type stuff has been reduced with stellate ganglion block. So Stephanie's asking, stellate ganglion block with Dr. Lau and someone else a couple of years ago didn't notice a change. Again, I think that's just kind of, if you tried to stellate and it didn't help, I have a couple of patients I've done 5 or 6 now, and they've maybe started to see some benefit. It just depends on, I don't want to take up too much of your time, but if you want to come in like for 3 months in a row, for 2 days and try that for, 3 times and see if that's worth it, that's fine with me. If you make the appointment and you agree with the physician beforehand that you just want to try it for a certain amount of time, it's fine. Some people have gotten benefit. I've had people get benefit after 3 or 4 who didn't get any benefit after 1, but they didn't really have anything else to try at the time. So they did. Someone had Bell's palsy years ago caused by food poisoning and still have some eyelid and upper lid weakness. Is there any risk of that palsy being reactivated by stellate ganglion? I don't know. I would think not. Like Bell's palsy is your facial nerve. As far as I know, like the motor nerve in that area, this is a different nerve. The vagus nerve is in that area, but it doesn't usually cause Bell's palsy. You might have both the vagus nerve being paralyzed and Bell's palsy, I guess. But I don't know what to tell you. I got nothing on that one. You could try the other side, I guess. So someone asked, did 80% of people have a stellate ganglion and 20% don't? If someone doesn't have one, will a different location be injected instead? No, you still have the stellate ganglion is just a name when the 2 different ganglion are combined, but people still have those 2 ganglion in that area. They're just not combined and looking like a stellate ganglion. Like if like in cadavers is where they just, they dissected it. They looked at what it looked like. They dissected it out. When they're combined, they look like a star. So they called it a stellate, but everyone still has those ganglia. Well, maybe not everybody, but vast majority of people still have those ganglia. So you just basically inject in the same general area and it'll get something. So Rick, can I ask you a question? Everyone can see these questions, right? So if I say people's names, that's okay?
People can't see them.
People, no one else can see them? The
Nope, just
questions?
no.
Okay, all right, I won't use names then. Can these side effects remain and have I had patients with this outcome? I guess maybe talking about like the droopy eye and the hoarse voice. That's an effect of the local anesthetic being injected. So the side effects that I mentioned don't remain. They can be a bit longer lasting. Like I had one patient tell me that they had a droopy eye for like 12 hours, but their nerve was just more sensitive to the local anesthetic effects, and it took a little while for it to be metabolized, but it went away. And someone's asking, they had a pain flare after stellate ganglion block going through the muscle, and then had very tight muscles in that area. And so can you do the stellate ganglion without going through muscles? Depends on the patient. Largely, yes. And it just depends on the anatomy exactly, right? So we have to be very safe not to inject in the blood vessels. So if I can, at least personally, if I can see a clear path, not going through muscles and still being able to get to my target without going through blood vessels, then yeah, I can do that. And someone asked, is potential complications short-lived or is damage to nerves permanent? That's a bit always on a case-by-case basis. Usually if a needle pokes a nerve, it can cause a bit of discomfort or dysfunction in the nerve for a little while, and then usually the nerve recovers. But there are instances where that pain becomes chronic. And I would say probably the central sensitivity population is one that's a bit higher risk for little pains becoming chronic pains. And someone asked what the spatial resolution of my ultrasound. I'm not sure how to answer that question. I don't know. I apologize. Someone has been told they have long lungs due to Ehlers-Danlos, and is it worth telling the person doing the stellate ganglion block? I think there's never a bad time to communicate with the person who's about to inject in your neck, really. So I would certainly tell them, but be comforted that if they're using ultrasound, you can see the lung, or you can see the lack of lung, more importantly. And so if the lung, you get a certain kind of view with the ultrasound, and you make sure the lung is not in your view, and then you make sure you can see your needle the whole time, and then you're not going to hit the lung, right? So that takes that kind of danger out of it. Someone else asking about the lack of ganglion. Even if you don't have a stellate ganglion, you still have a sympathetic nervous system in that area. And so you can still do an injection in that area. Yeah, so someone says they have ME, fibromyalgia, and Ramsay-Hunt syndrome and have increased pain. And so that's a whole bunch of stuff that's, that combination hasn't been studied. Some of those individual things have been studied. Stellate ganglion block can decrease pain and symptoms from some of those things. So I think it's more, I don't know the person who wrote this, I don't know their exact situation. But I think that's the kind of thing you have to have a talk with your physician about, because especially when you're a bit more complicated, the weighing the risks and benefits becomes maybe a bit longer of a conversation. Maybe before you get an injection in your neck, maybe you have injections in other areas that are less sensitive to kind of see how you respond. And, gain some comfort, getting injections in general. Like you don't want to have like a needle in your neck and all of a sudden you can't handle it and you start flailing, right? That's, no one's gonna like that. Yeah, so someone's asking about stellate for lost taste and smell. They just, some people do get their taste back. You know, there's smell and taste, and there's even physiotherapy, which, you know, maybe this person has tried for, you know, I don't know that much about that, but they like make you smell cinnamon, they make you smell mint, like kind of like stronger scents that you can recognize, and then, you know, work your way up from there. But, you know, I think, as I said, I have a couple of patients I've done the injection for smell and taste. It seems like those are some of the hardest symptoms to get back, or the hardest sensations to get back to treat. And someone said they had a spinal block and had severe side effects. Is this the same? I don't know exactly what you mean by spinal block. There's like if it was for surgery, or maybe you had just an injection in your back for back or neck pain. I guess there's some similarities. You know, it's kind of hard to tell sometimes. Sometimes for some people, they're just so sensitive that putting a needle into their body is gonna give them a severe side effect. And you know, you might be one of those people. It also might be that they did a very deep spinal block. They had to cover a lot of ground, or they injected a lot of medication, or they injected steroids, and you had a bad reaction to one of those things, not the actual needle pain. So maybe it's not the same thing, you know. So the side effects from stellate ganglion block are pretty well defined. Possible complications are, you know, in a central sensitivity population are, you know, those pain flares, you know, muscle tightness, as someone else said, you know, there is always that possibility. So you just have to kind of weigh the possible benefits for yourself. And someone's asking about blood thinners. So there's recommendations for all the various blood thinners. There's like fairly large studies, like a couple 100,000 people that they rely on. So they're pretty good. And for something like a stellate ganglion, it sort of depends on the person. Like I kind of base it on the person, the patient. The stellate ganglion block is done in an area that you can somewhat compress. So it sort of depends on the patient, but I sometimes do and sometimes don't take patients off a certain, depends on the blood thinner also, you know, versus antiplatelet, that kind of thing. So it sort of depends. It's always situational. I can't say for you, you know, what I would do. I generally am okay with patients staying on or not coming off all the way their blood thinners or antiplatelets for this particular injection. But that might not be the same for other physicians. They might not feel the same way. So it does have to be a conversation that you have. So someone's asking, are there contraindications for stellate ganglion block in obstructive sleep apnea? Are there any other conditions? There's not a lot of contraindications for stellate ganglion. Certainly obstructive sleep apnea is not a contraindication. It doesn't really cause, you don't go to sleep or anything with this. So don't worry about that. And what are you injecting? Usually just local anesthetic. So either lidocaine or bupivacaine or a combination of the two. And how is it different from Botox? Well, Botox is specifically taken up by nerves and stops them from functioning usually, you know, injected in muscle. So it interrupts the neuromuscular junction. And local anesthetic stops the nerves from firing, but only for a short period of time. Botox lasts, you know, 10, 12 weeks. How regularly do I do the stellate ganglion block? I probably do, I don't know, maybe 10 a week or so. And there's no cost for a local anesthetic injection of the stellate ganglion block. That's MSP covered. Some clinics charge for the local anesthetic. We just don't do that at ChangePain. Some places do. Other places don't as well. You know, it just depends on the clinic. If you want steroid, at least at our clinic, we write your prescription and you go pick it up at the pharmacy. You can buy it from the clinic as well. It's not super expensive. So usually you can get a stellate ganglion block with no out-of-pocket costs. Wait list to ChangePain is a couple of months right now. If you get referral, or like we have a separate referral list just for procedures, not for ongoing management. And that is a bit shorter sometimes. Someone's asking how many injections to relieve ME or fibromyalgia on average for treatment. I've never done this for fibromyalgia. There's that one little study, but generally fibromyalgia is so widespread that I don't think it's worth doing this specifically for fibromyalgia. Maybe I'm wrong about that. Maybe there's some other benefits that weren't mentioned. I don't know, but I don't do it for that. For MECFS, in those studies, which are very poor quality studies, so you can't really rely on them. But in those studies, a lot of people got benefit after just 2. Some people got benefit after 1. But then we don't really know how often you have to do it again, how long it lasts in any given person, which population is going to last longer, and that kind of thing. We don't really know. So to totally relieve MECFS, that hasn't even been studied. It's really just long COVID, which might just be kind of a subcategory of that. But I can't really tell you, how many injections to relieve it. But maybe you'll get some relief after 1, maybe a bit more after 2. Maybe the second one won't add anything, and maybe you can keep going and keep getting more benefit. So it depends on the person. Yeah, the injections I do, like if I do an injection with local anesthetic, someone's asking, are the services covered by MSP or insurance? We take MSP here. So if you have MSP, you can get an injection with local anesthetic. Some of the other stuff, like the radio frequency stuff or the cryoablation, or if you want to inject a special medication besides local anesthetic, there's some costs associated with that at this clinic. So anybody can come here. But if you're going to get those other special things, or if you qualify for those other special things but can't afford them, we refer to like St. Paul's or Jim Pattison in the Lower Mainland, and they can do some of that stuff. Will this help with chronic pelvic or perineal pain syndrome, or is a more localized block necessary? Probably more localized. It probably depends a bit on the reason for the pain. Like sometimes people that have chronic pelvic pain, if you got like PTSD along with it, and you treat the PTSD, that can help the pain. So you can think of some situations in which it might be useful, but generally, it's very far away from the pelvis, so injecting it probably won't help the pelvis. There is sympathetic blocks for the pelvis. Or for the like visceral organs, as I said, like the celiac plexus for like the stomach or pancreas or liver. You can do a ganglion of impar, for instance, for pelvic pain. So there is other areas to inject the sympathetic nervous system that might be useful for different people. And so someone asks, it's covered under MSP, but can one pay privately to get this done in a more timely manner? Maybe not at our clinic anyway. If a doctor takes MSP, then there's rules around taking MSP, which means all MSP patients get in the queue. You just get to the back of the queue. So you can probably find people that don't take MSP and pay them and get it done quicker. Although you can get it done, I don't know, a couple months here at ChangePain, probably within the next like 4 or 5 months. Or there are other pain clinics like in the Lower Mainland. I don't know everybody's wait list, but they can't be more than a year for a lot of places, and probably a lot of places are just a couple months. You know, I know that a lot of GPs will refer to just a couple clinics, see where you get in first, you know. Are patients with facial erythromelalgia possible candidates for stellate ganglion? I think that would make a great case report. I didn't see anything about erythromelalgia in there. There's a whole bunch of other things that are used to treat erythromelalgia. You know, it's a issue with sodium channel, so using sodium channel blockers, basically. I don't know, it sounds interesting. There's some evidence from kind of idiopathic facial pain and other kind of facial pain. So I don't know, it might be worth it. Oh, someone asked, could this help chronic nerve pain at the site of a tooth removal? I did not include that. But there are case reports about using a stellate ganglion block for pain after teeth, like dental work, and burning mouth syndrome. So there you go. There's a case report for burning mouth syndrome. So burning mouth syndrome, there's a couple different nerves in the mouth, different cranial nerves. And so sometimes, blocking stellate ganglion block might be helpful, but also blocking those nerves more directly might be useful, like glossopharyngeal nerve for like kind of the throat area, in the base of the tongue, blocking trigeminal nerve in a couple different places for the top of the mouth, or even kind of the forward part of the tongue. So there's a couple other things that can be useful in burning mouth syndrome, specifically besides stellate ganglion block. And is there a physical or health downside to what is being blocked by the injection? Not that I know of. It's just, so it depends what's being injected. If it's just local anesthetic, no, there's no real systemic effects. It goes in, it blocks some sodium channels in the nerve, and then it kind of just dissipates and your body metabolizes it. And there's no like issues with the metabolites that I know of. For vast majority of patients, like sometimes the preservative has been shown to be affected, but usually that's when you do spine injections, that kind of stuff. If you're talking about injecting steroids, yes, there can be some downsides. As you know, there's some short-term effects of steroids, like increased energy, wanting to be like getting really hungry and having to eat, having trouble sleeping after an injection of steroid just for the next night or two. But it's more like when you get a lot of steroids, so like more than 4 or 5 times a year, or if you get it directly into a joint, there can be some downsides into the joint for that joint. So steroids are like immunosuppressive. They can increase your blood glucose after a lot of them. They can decrease your body's own production of their own corticosteroids. So there's, you know, weight gain in weird places, like skin stretch marks that can happen. So corticosteroids can have some health downsides if you get too many of them. Getting a couple injections a year is generally considered safe as long as the effect is worth it, right? So it's always a risk benefit. Someone asked, do I know of any doctors in the Okanagan that do this procedure? Yeah, there's a pain clinic it's not Kamloops, it's that other Kelowna there. So there's like an interior health pain group. And so I know that the one in Kelowna has doctors that do this kind of stuff. And then they have I think like if you look up the pain clinic in Kelowna, they have a couple other listed clinics associated with them. So I don't know, a lot of those are like kind of GP pain. So they might not necessarily do this particular injection. But once you're in that system, maybe they can refer you down to Kelowna or up to Kelowna or whatever to get this done. And there is, like, if you're in the Okanagan, there is a pain clinic, like a community pain clinic, not healthcare authority. Is it out in Abbotsford? Maybe there's one out there. So anyway,
Initium Clinic Abbotsford and the Kelowna Nerve Block Clinic in Kelowna.
Thank you. Someone was asking, should they stay in Victoria or go to Vancouver? I guess if you can get it where you live, you can do it. I know that there's Victoria Hospital, Victoria General, whatever, has a pain clinic. There's another pain clinic that's kind of like ChangePain that's over there. So there's people doing this on the island. And no, there's no cost to it's just MSP covered. So there is a cost, but you're not paying it. Don't worry about that. This does require a GP can refer to our clinic. Yeah, someone's asking to get this procedure. Can a GP refer, or does it require a specialist referral? You just get it referred, and then it's a discussion between you and whatever doctor is going to do it, whether or not the procedure is worthwhile. And someone's asking, just to make sure, long COVID was mostly helped with chronic fatigue and brain fog. Yeah, those were it seemed like the things that were treated most by the stellate ganglion block. So people that had long COVID and had chronic fatigue and brain fog and a whole list of other symptoms, and it was a brain fog and fatigue that were the highest treated, like the highest rate of treatment. And my POTS patients, did they see improvement? I only remember the results from one. To be honest, I don't know if I've seen the other person yet, but that patient did get benefit, partial, like a little bit less racing heart. So, or that's whatever that's worth. Can this help with high or volatile blood pressure? I don't think so. Can it help with tremor? Not that I know of. Can it help with hip or back pain? Probably not. You usually want something that's a little more targeted to the area. So if you have like pain in a given body part away from the head and face, usually what we do is, because I use imaging, like I said, ultrasound or X-ray to guide needles. So I can do that kind of head to toe, or just like interventional pain physicians can kind of do that into various areas. That's kind of what our whole specialty is about, is targeted diagnostic injections to find out if a certain body part is causing you pain or not, and then designing treatments that are, again, targeted to that area, as opposed to something like, just giving everybody amitriptyline or gabapentin and sending them on their way. We try and do a bit more targeted, so that we know, okay, you say your back hurts, is it your lumbar spine, or is it your lumbar discs, or is it your sacroiliac joint, that kind of thing, right? So a bit more specific. And is stellate ganglion a possible option for patients who also have high blood pressure? Yes, that's fine. So someone says, I mentioned right-sided stellate ganglion blocks, which failed, but then left-sided worked. That was specifically for PTSD. They did the injections on the right, and it didn't help the PTSD, so they did the left side. If we're treating pain symptoms, I usually treat on the side of pain, right? Like if someone has nerve pain on their right side, or like post-mastectomy pain on the right side, then I would usually inject on the right side. Same, left and right, that. The chance of nerve damage. Someone asks, how often does it cause nerve damage or other serious complications? Extremely low. Like less than 1 in 1,000 to be very serious. Like I would say, majority of people get eye droop, majority of people get hoarse voice. I had a patient the other day who was vomiting afterwards, but they also liked they also had more energy, so they felt like it was worth it. So, but like nerve damage or the hole in the lung thing or hole in the esophagus or whatever, all that's extremely, extremely rare. Yeah. And someone asked, well, I administer Ativan for nervous patients prior to injection. So we don't do sedation here, but you can get that in the health authority. So if you need like actual sedation, you can get that in the health authority, like St. Paul's. I will, once I get to know a patient, sometimes do like 1 or 2 milligrams of sublingual Ativan. Yeah, and I think that's fine. Or if you get it from your GP, just let me know you're taking it. Basically, I just want to get consent for the procedure when we talk, but on like a day previous to the actual injection, so that you're not under the effect of Ativan when I'm getting consent. Just for my own, just so I feel like I'm doing the right thing, basically. Someone asks, if the block is successful, would it be something you just repeat, or would it be something you'd rather do the radio frequency on? Usually I would just repeat it. Like it's super low risk to just repeat. There's no money involved. So I think it's almost always worth it to just repeat it and just see if you get further benefit or if you can keep the benefit going. You know, if you do the injection and you get a day of benefit, and then we've done it now, 4 times and you've never gotten more than a day. Okay, now you're talking about it's not worth necessarily doing the injection because you can't come in every day for that, right? That's just not worth it. So now you got to start looking at ways to elongate the effect. Or if, you're traveling from really far away and, you're like way up north and traveling down here takes you 20 hours. So getting down here every month is really difficult. Then maybe we might talk about ways of elongating it so you don't have to do that kind of thing. And someone asks, how do you proceed if you want to get this procedure and you're already with ChangePain? You just tell the front desk that you want to make an appointment with one of the procedural, like image-guided physicians. If you're already seeing it, like that's me, Dr. Brenda Lau, Dr. Berkman for another 20 days or so. And then we have some trainees that do what we do. So any one of them. And someone asked, does stellate ganglion block result in increased blood flow to the brain? It does decrease sympathetic outflow to the brain. So I read about this a little bit actually the other day, and the brain does a lot of its own kind of auto regulation of blood flow, but there is some evidence that stellate ganglion block probably does increase blood flow to the brain. Yeah. Is there an explanation why stellate ganglion works in some people and not others for symptoms of dysautonomia? And if it doesn't work for you, is there anything that can be done before trying again? There is not a good explanation for why it works in some people and not others. We don't really know who it works on or why. And that just goes back to the kind of very low quality studies, but also because there's not even a good kind of, there's a bunch, I read like 2 or 3 different theories about why stellate ganglion block works for all these different things at once, right? So we don't really know, these are a bunch of things that we don't know. And if it doesn't work for you, is there anything that can be done before trying again? Not that I know of. I guess, you can try and adjust medications, see if you can get like a bit of further improvement, but ultimately, as I said, I've tried with I have a couple of patients who I'm just kind of continuing to try, and we're just seeing if we do it like 4 times, 5 times, is that helpful? At some point you got to give up. And, give it maybe 6 months rest, come back again if you want, that kind of thing. But, we don't really know. And to treat neuropathic pain across the chest from left to right sides, would the stellate ganglion block on both sides need to be injected, or would only need an injection on one side? So one, I don't know if it would help the neuropathic pain in the chest or not. Maybe it would, but it is a paired thing. So there is a left side and a right side. So it depends, like if the pain all comes from one side and you feel it kind of radiating to the other side, then maybe doing it on just the main side, it would help. But probably if you got pain on both sides, you probably have to do one side, then the other. And someone else asked the name of the Victoria Pain Clinic that does these. Dr. Arsenault, do you want to step in again here? Do you remember the name of that?
Can't remember.
Thanks.
There's a Nanaimo Pain Clinic, but not Victoria. Bruno's.
Yeah. Anyway, it's on Google Maps. I remember I've looked it up a couple times. Someone's asking if you have no pain, but huge problems with fatigue and brain fog, is a procedure recommended? Yeah, those are certainly symptoms that have been shown to be improved with stellate ganglion blockade. I guess sort of depends on why you have those. And would the dose of anesthesia be different if the patient regularly needs higher doses, like at the dentist? Maybe. I don't really know. It's it. Usually I inject bupivacaine, not lidocaine. The dentists usually inject like a lidocaine, like a shorter acting medication. Those interact with the sodium channel just a bit differently because it's a different drug. But yeah, I mean, if you get just partial relief with a couple cc's, you could increase the dose, sure. See if it's more helpful. That's something just to have a discussion with who's ever doing the injection. Someone asks, there's a cyst in the upper front of their esophagus. Would it be beneficial to look at removing the cyst and the injection of stellate ganglion, or just the injection? Well, certainly, I got nothing to do with removing cysts anywhere. So I don't know. I just don't know like what the benefit of, if there's a benefit to removing it. But as long as it's not in the way of doing the injection, you can still try the injection, as far as I know, as long as it's just been proven to be just a little cyst, that's okay. Someone's asking, does Dr. Archilia ChangePain do this procedure? Yes, he does. As does Dr. Nasser, Abrazi, Dr. Lau, and myself. Ooh. Made a wreck. I don't have any more questions.
Okay. And you've got 1 minute left, so perfect timing. Thank you so much. And I've sent Dr. Burns an email so that he can tell us when he's available to do another talk. What I'm particularly interested in the next talk is patients with fibromyalgia can get other pain conditions that are not fibromyalgia, but that flare their fibromyalgia. And so what are the kinds of procedures that are available for people who may have coexisting bursitis or tendonitis or spinal disease or anything like that? So we're looking forward to that. I learned a ton today. Thank you so much. That was fantastic. Have a great week,
Thank you for
everybody.
having me. And I just want to say all those patients that gave me just a quick shout out. I did read those. Thanks very much. Thanks, Rick.
Okay, have a great day.